Okay. Well, hi everybody. Welcome. So great to have all of you here. I'm Alan Weissman. I'm one of the co-founders of Radimal, and thank you so much for joining us today. We are really excited to have you here for this live CE webinar on mastering intraoral radiography in dogs and cats. Today's session is all about giving you the tools to capture better images, avoid common mistakes, and of course, feel more confident when reviewing dental images. And if this is your first time meeting us, Radimal is a leader in veterinary radiology services. We provide AI-powered assessments with board-certified specialist consultations to help veterinary teams get fast, reliable imaging insights 24/7. Now, I'm really excited to introduce today's presenter, Dr. Nadine Fiani. Hi, doctor. Thanks so much for being here. We had the pleasure of getting together up in Ithaca at Cornell just a couple of weeks ago. And Dr. Fiani is a board certified veterinary dentist. She's also associate clinical professor of dentistry and oral surgery at Cornell University College of Veterinary Medicine. She also loves teaching, and I think is just pretty excited to be able to present today. So thank you so much, Doctor, for being here, and thanks to all of you for just giving us a great reason to present all of this. Before we do dive in, as the session is going on, Dr. Fiani has requested that if questions come up, as questions come up, please just feel free to put them in the chat. I'll be doing my best to help monitor some of the questions and help jump in from time to time. And otherwise, we'll let Dr. Fiani take the lead here. Thank you, Doctor. We'll hand it over to you.
Thank you. All right, let me see if I can share my screen here. All right, and let's see. Here we go. And if I can find the laser pointer. There we are. All right. Okay, well, welcome everybody. I'm so excited to be here. And I'm even more excited to just see how many places are being represented right now, both nationally and internationally. And I really, really hope that this talk is going to be beneficial to you. I've tried very hard to make it as practical as possible. It is based on my many, many years of being a veterinary dentist, working with referring veterinarians, both in private practice and in academic settings. So I really do hope it's going to be useful. The aim of the talk is to sort of be light and helpful and more chatty. So I am more than happy for you to pop your questions in. We are going to see how we're going to handle that with more than 300 people in attendance. So I will do my best. I have some quizzes, some questions to ask, and sort of I hope that you will participate openly. And we can see where everybody's going and how everybody's learning as we move it along. All right. So let's see. Okay, so the objectives for our talk today are as follows. First of all, I want to sort of describe what the benefits of intraoral radiology are. Really, why are we bothering to do these at all, and for what sort of purpose? We are then going to cover a little bit of normal radiographic dental anatomy and a little bit about dental physiology, because ultimately these are crucial in order to help us understand when disease is present and eventually how to manage that disease. I'm sure many of you have tried to take intraoral radiographs and have run into some troubles with it. It is a finicky and tricky set of skills to obtain. And so we're going to go through the principles, just the basics of how to get various radiographic images. We won't have time to go through every single view, but we will talk about the principles. We're then going to cover some really, really common mistakes. Finally, we're going to talk about how to orient intraoral radiographs and labially mount them. Hopefully, all of you guys have been sent a bunch of intraoral radiographs from cats and dogs. So those are full mouth series. If you've had the time to sort of print them out and sort of play with them, fantastic. Otherwise, I believe you're going to get a copy of this talk later on down the line, so you'll be able to play with that later as well. And then finally, we'll go through how we try and interpret intraoral radiographs. Okay, so starting off, what are the benefits of taking intraoral radiography? Well, the important thing when it comes to dentistry in general is that the vast majority of diseases that we deal with are in fact subgingival. They are below the gum line. What you see with your eyes is only part of the picture. And so by taking intraoral radiographs, not only are you visualizing the anatomy, of which there is quite a bit of variation, even within the same species, but you're also being able to recognize disease processes. So intraoral radiography started becoming more and more of the gold standard. It is definitely the gold standard now for all of any dentistry procedure that's being performed. But really what triggered all of that was a series of studies that were done sort of in the late 90s, early aughts, where they looked at a bunch of cases, and basically they initially started off by looking at teeth with obvious evidence of disease. They looked at the oral examination. These were teeth that were either fractured, had tooth resorption, severe periodontitis, whatever. There was obvious disease on them. And what they found is when they took radiographs, they gained additionally clinically useful or even essential game-changing information in 72% of dogs and 86% of cats. So they gained even more information, even though they already know that a particular disease process existed. What's terrifying is when they started looking at teeth that looked pristine and completely normal on oral examination. And what they found is that they noted clinically important lesions or game-changing lesions, essentially, in 27% of dogs and 41% of cats. That's terrifying. That's like nearly half of the cats that we are looking at have something going on below the gum line that matters, and a quarter of the dogs. Okay, so this is where, when these studies came out, that was sort of the pivotal change to encourage everyone to start taking intraoral radiographs and sort of prevent yourself from doing dentistry with one arm tied behind your back, if you will. Okay, so for those of you who have tried, I completely see you, and I totally know what a steep learning curve it is to take the radiographs. Intraoral radiographs are technically super, super challenging to get your head around and to get used to taking. But once you've gotten the hang of it, it is wonderful, and you can get very fast at them. The annoying thing about dentistry as a whole is, as a rule, not only are we expected to have this incredible skill set of obtaining diagnostic images, but while the patient is under anesthesia, you have to be able to interpret those images and come up with a treatment plan and treat the patient all in the one anesthetic event. At least that's sort of the premise. Allow me to absolve you. You do not necessarily have to do that depending on the amount of disease that you are encountering. But regardless, it is a heavy lift to ask of anyone. Okay, so moving on, let's talk a little bit about basic dental radiographic anatomy. So over here, we have an intraoral radiograph of a maxillary canine from a dog, and over here corresponding to it is a little cartoon image of a tooth. So the outermost layer of the tooth is covered by the hardest substance in the whole body, and that's enamel. Enamel is highly, highly mineralized, and you can see it here as a slightly radio opaque layer. In carnivores, the enamel layer is very thin compared to herbivores or omnivores, where their entire job in life is to sort of grind down food, so they need a much thicker layer of enamel. But in dogs and cats, it is relatively thin and not super easy to see. The bulk of the tooth, so that's the majority of the tooth over here, is made up of a material called dentin. Dentin is also highly mineralized, not quite as much as the enamel, and it is made up of sort of a tubular structure that allows some flexibility within the tooth itself. The outermost layer of the root is covered in a thin material called cementum. Cementum is the same radio opacity as the underlying dentin, and so radiographically, you cannot discern it from the dentin itself. The central portion of the tooth you can see as a radiolucency, and that is the pulp cavity. The pulp cavity contains the neurovascular supply for the tooth. So The nerves and the blood vessels enter into the tooth through the apex. As you can see here, something called the apical delta. It's a series of little channels where the blood vessels and nerves enter into the tooth, and then they fill up this entire cavity with the pulp material, which is nerves, blood vessels, and a highly, highly important cell called the odontoblast. And we'll meet that guy in a minute. So that is the pulp cavity in here. Okay, that is the structure of the tooth itself. Now, there are very important structures surrounding the tooth that hold the tooth in position, and that's the periodontal structures. So the first thing that you're going to be able to see is alveolar bone. So alveolar bone is the bone socket that the tooth sits inside. The alveolar bone is continuous with the rest of the jaw, and you can see that the alveolar margin, which is just the very top of the alveolar bone, should reach up to the cemento-enamel junction. So where the cementum and the enamel meet each other at the neck of the tooth, that's where the alveolar bone should be in health. This very thin black line around the tooth represents the periodontal ligament space. So the periodontal ligament is what suspends the tooth in that alveolus. And the periodontal ligament itself can't be seen radiographically, but you can certainly see the space that it occupies. Okay, so as far as other structures that make up the periodontium, which are the gingiva and the cementum, the gingiva can't really be seen. It's a soft tissue structure. In some older dogs, it can sort of calcify over time, and maybe you might be able to spot it then. And the cementum, as we already pointed out, is the same radiopacity as the dentin. So that is the basic tooth structure. Now, as I said earlier, there is some physiology involved in dentistry, and that's the physiology of tooth aging. So the pulp inside the tooth, which is probably the coolest part of the tooth, is very much alive. Again, we said there's nerves and blood vessels that enter the tooth through the apex. And surrounding all of that, so on the periphery of the pulp, is this highly, highly, highly specialized cell called an odontoblast. The odontoblast has one job in life, and that's to make dentin throughout the life of a tooth. So what we have here is completely normal aging of a mandibular canine in a dog. When a tooth first erupts, it is not completely formed yet. You'll notice here that what you have is a very thin layer of dentin and this huge pulp cavity. You don't even have an apex yet. The bottom of the tooth hasn't actually formed. This is a typical 6-month-old dog radiograph, completely normal. As the tooth ages, the odontoblasts make more and more dentin, and therefore the dentinal walls become thicker and the pulp cavity becomes narrower and narrower and narrower with age. This is completely normal. So I have a question for you guys. If I take a tooth at this age, let's say it's about a 1.5-year-old dog, and I come along and I kill the pulp, what do you think this tooth will look like when it's 2 years old? Is it going to change in size, the pulp cavity? Feel free to pop your answers into the chat. Don't all jump in at once. Pulp will stay the same. Perfect. Oh, I love it. Yep. Spot on. So there, now you understand endodontics. That is endodontics in a nutshell right there. And we'll come back to that later. Ah, so good to see. So on radiographs, if the pulp dies, if those odontoblasts die, they are no longer making dentin. And this is a critical part to understand when you're thinking about tooth physiology. Okay, perfect. We are still on normal anatomy. Okay, so this is just a very quick little recap of the dental formulas, and I'll go through dog and cat. So dogs have a total of 42 teeth, assuming they have all of their teeth. Where I think this is really critical is if you're operating on any patient, you should be familiar with their anatomy. But also when it comes to dental radiology, knowing the anatomy of the teeth intimately becomes critical in order to identify what radiograph you're looking at and where you are in the oral cavity at all. So very helpful to know the tooth structure. So in the maxilla, there are 3 incisors, 1 canine, 4 premolars, and 2 molar teeth in the dog. Looking at their root number becomes very critical here. The incisors and canines, a total giveaway. Very easy to remember. They're always single rooted. Where it gets a little hairy is your premolars and molars, trying to remember what's going on there. So I'll give you a little helpful hint that I use with students, and they seem to retain it reasonably well. If you're trying to remember the root number in the maxillary teeth for the premolars, it goes 1 1, 2 2s, and 3 3s. Right? So P1 has one root, P2 and P3 have two roots, and so on. In the mandible, again, 3 incisors, 1 canine, 4 premolars, and this time we have 3 molars in the mandible of the dog. Incisors and canines, very easy to remember, single rooted always. But again, it gets a little hairy after that. So in the mandible, you start with a 1, you end with a 1, and everything in between should be a 2. Okay, so just some nice, easy little reminders. Again, you guys will be sent all of this stuff out, so you'll have that available to you. Okay, cats. Cats are a pain. Cats are a little harder to remember because even though they have fewer teeth, they have a total of 30 teeth, their anatomy is a little bit more evolved than dogs. So what we know is across species, as a species evolves, their faces tend to get shorter, which means that they don't require as many teeth. And the teeth that are lost are typically lost from the start of the premolar row and the end of the molar row. And so that's where the numbering system for cats can get a little bit crazy. We have normal number of incisors and canines, 3 incisors, 1 canine. And then in the maxilla, for instance, all of a sudden we start at the second premolar. But cats have lost their first premolar from an evolutionary point of view. And same in the mandible. They've lost their first and second premolars. And so we start with the third premolar. And both upper and lower, we've lost the second and third molars altogether. In fact, the first molar in the cat maxilla is vestigial. It's on its way out. In a few thousand years, this won't be there anymore. Okay, as far as root numbers go, just something to help you remember, incisors and canines, always a giveaway. And I wish I had something as fun as the dog, but in the cat maxilla, it goes 1, 2, 3, 1. Sort of just like music. In the mandible, 2 rooted only. No single rooted, no 3 rooted, 2 rooted only for the premolars and molars. Okay, so that was your little refresher for normal anatomy in the dentistry of dogs and cats. Okay, so now we'll move on to the principles of obtaining intraoral radiographs. Let's start with something that everyone's a bit more familiar with, and that's traditional radiographs of a limb or a chest, for instance. And with those, we typically take what's called a parallel view. So what we have is the anatomy of interest. In this case, it's a leg. We then have the X-ray plate, which is parallel to the anatomy of interest, which means that our X-ray beam is perpendicular to both the anatomy of interest and the plate itself. And that gives us a very nice image of the anatomy that we're interested in. Annoyingly, however, the oral cavity will not accommodate that particularly well. And the reason for that is in the maxilla, we have a hard palate. So if I try and stand the X-ray plate so that it is parallel behind the teeth of interest in the maxilla, I'm never going to be able to get it up behind the roots themselves because the hard palate is in my way. And the same principle goes for the rostral mandible. The symphysis is simply in my way. I cannot get that plate low enough because it hits the symphysis. So my plate is never behind the roots. The only location in the entire oral cavity where it is plausible for me to take a parallel radiographic view is the caudal mandible. And the reason for that is I simply have space. There is soft tissue between the two parts of the caudal mandible, and I can really push my plate up in there in order to have the plate sitting right behind the teeth, including their roots altogether. And so how do we take this view? So in this case, we typically have our patient in dorsal recumbency or lateral recumbency, depending on how you prefer to do your dental procedures. We place our plate so that it is parallel with the long axis of the teeth of interest in the caudal mandible. We make the side of our X-ray unit parallel to the plate, which means that our X-ray beam is perpendicular to the teeth of interest. and that will give us a perfect representation of the caudal mandible. So that is the only spot in the entire oral cavity where this view is possible. So that leaves us with a bit of a conundrum, because how do we get past those anatomic limitations of the entire maxilla with that hard palate and that rostral mandible where we have that symphysis in our way? All right, so I'd like you to come on this little journey with me, and I want you to imagine the following. We have a stick that is standing in the ground, and we're going to think about the kind of shadow this stick will cast. So when the sun is really high up in the sky, so we're talking about midday, the shadow that's being cast by the stick is very short. However, as the day progresses and we get to either dawn or dusk and the sun is much lower in the sky, we are going to cast a very, very long shadow. Now, when the sun is exactly between the earth and the stick, the shadow that is cast is a perfect representation of the stick itself. So keeping that in mind, how do we apply that to all those areas of anatomy that are kind of limited? So in this analogy, we're going to do the following. The plate is going to play the role of the earth. The tooth is going to play the role of the stick. And your X-ray unit is the sun. Okay, so we want to be able to move that sun in order to have it exactly between the plate and the tooth of interest, so that when it casts a shadow, so when you take that X-ray, you're casting a shadow that is going to be a perfect representation of that tooth of interest. So this is a left maxillary canine tooth, and you can see that it is a perfect representation of that tooth. It's not too long, it's not too short, it's just right. So how do we figure out where to put our sun, so to speak? And that is where we have developed something called the bisecting angle technique. And this is how we basically work it out. We have our plate, which is the ground. We have our tooth of interest, in this case, the canine. Now, in order to figure out where to put the X-ray beam, we're going to do the following. We are going to bisect the angle between the tooth of interest and the plate. So we want to cut that angle in half. In this case, it's really nice. It's a perfect 45-degree angle. However, it doesn't matter how wonky the tooth is, as long as you stick to the principle of bisecting the angle between the plate and the tooth, this will work. You then take your X-ray unit and make it parallel with the bisected angle, which means that your X-ray beam will be perpendicular to the bisected angle. What this will do is it will give you the perfect representation of that tooth in shadow form, if you will. So it allows you to place your sun or your X-ray unit in that perfect position right between the plate and the tooth of interest, casting a perfect shadow for you of that tooth. Okay. Does anybody have any questions? Because this seems to be one of the areas where people often get a little bit stuck. All right, super. Okay, so we are now going to talk a little bit about some common technique mistakes. And this is where I would love for you guys to use the chat and tell me what you think is wrong. And then we'll talk about how we might be able to correct it. All right, so here are a couple of images. Do these look good to you? How do you get past the ETT and tongue? Elongated, perfect. So somebody just very quickly asked, how do you get past the endotracheal tube and the tongue? I actually just use a tongue depressor on top of the endotracheal tube and the tongue to sit my plate on. All right. Okay, some people just don't like it. It's a big no from Caroline. But everybody else is saying elongated.
We have a lot of
Fantastic.
elongateds, and if it's okay, can I share a couple of other questions?
Of course.
Great, great. So, Mary was asking for suggestions for keeping their sensor in place beyond normal gauze. Is there putty or something that can be used?
The sensors are really challenging.
Hmm.
Largely, we actually use X-ray plates in there. We have little photophosphor plates that are much more user-friendly. The sensors are really bulky, and that's one of the downsides of having a direct radiographic option in there.
Sure.
Listen, you use whatever you need to get that in there. There is definitely all sorts of putties that you could potentially put in there. There's dental putties out there. But the gauze is typically the best way to do it. It is a challenge for sure. Oh, look at that. People are sharing their little ideas. I love it.
Oh, yeah, look at all that. Okay,
Yeah.
great,
All
great.
righty.
One more person just looking for some suggestions. Leslie was asking, how do you do this with the patient in lateral?
I would struggle to answer that because I do all of my
Okay,
dentistry in dorsal recumbency. And so when I'm taking radiographs, they start off in sternal, I do the maxillary views, and then I flip them over into, they start off in sternal and then I flip them over into dorsal to do this. And it tends to be much, much easier. So in all honesty, I would suggest that you do it in either sternal or dorsal to make your life a little easier. If you prefer to do your dentistry in lateral, by all means, flip them over at that point.
great, great. Thank you.
Yes. And in
Uh,
order, oh, I can see a lot of people talking about sticks. So
yep,
yes, in order to work out all your little bisecting angles, absolutely use a couple of sticks, one to, pretend to be the tooth, one to pretend to be the plate, and then you use that to sort of flick it down and calculate your angle, if you will. Okay, so back to the radiographs. Everybody is spot on. That is an elongated image. These are way too long. And as you can see here, this rostral mandible, super, super long, looks like a runway. Over here, it's a caudal maxilla in a dog, and you can actually see that we've overshot the runway. Most of these teeth have actually fallen off the edge of the plate altogether, too long. So here is the position of the X-ray unit when we took this elongated image up here. Where do you guys want to move this X-ray unit in order to correct the image that you see in the top corner, this elongated, up higher, love it, 45 degrees, boom, boom, boom. Fantastic, you guys are spot on. That's exactly right. We want to slide that up, recalculate our bisecting angle, make sure that it's parallel with the side of our X-ray plate. We have a perfect 45 degree in this patient, but again, if you've got a weird brachycephalic or a cat or something unusual, whatever the angle is between the plate and the tooth is what you want. Amazing. I love it so much. All right. I don't know if I've missed any other pressing questions, but perhaps we should. Oh, Alan.
I
Alan's
think
back.
I think you're doing great. I think you're doing
Okay.
great. Love the answers. Thanks.
All right. Fantastic. All right. So there we go. We've corrected it. Now we have a beautiful representation of that tooth again in shadow form. I can't tell you how helpful it was to me to come across the stick in the sun analogy. Okay. Here we have a radiograph of a lateral canine tooth and a caudal maxilla. What does everybody think about this technique? Do we think that these look good? Ah, oh, here we go. Meg's got it. Foreshortened. Yep. The sun is not in the right spot. All right. Everybody's got it. Foreshortening. I love it. Okay, so here's our X-ray unit in position, and we obtained this terrible image. So how do we want to correct this time? Come down. The sun is too high in the sky. Exactly. There we go. So we're going to bisect the angle, put our bisect the angle, make sure that our X-ray unit is parallel with that, and that will give us a perfect representation of the tooth instead of being a foreshortened image. Wonderful. Okay. What do we have here? Is everybody happy with these images? What do you think might be wrong here? Not centered, cone cutting, cutoff. Oh, I love it. So, oh, look at that. You guys are amazing. Do you even need to be here? What's going on? All right. You're absolutely right. Well, this is called cone cutting, or it's a collimation error, really. Welcome to the frustrations of intraoral radiology. We have a one-size-fits-all dental X-ray unit. So we have no capacity to, in fact, enlarge or minimize the size of our aperture for the X-ray unit itself. That's it. That's what you have right now. And so it is so, yes, I can see the frustration. So it is a real challenge to ensure that the anatomy of interest is encompassed within the X-ray beam as you are trying to take your X-ray. It is a very common error. We all do it. I still do it to this day if I'm not paying attention. So here is an example of our current X-ray unit position. And this is the image that we got. Where do you guys want to move the X-ray unit to? Love it. A little bit to our left on the screen or the animal's right. That's it. Or center it. Exactly. Exactly. There you go. So you've shifted over a little bit and now you've encompassed all of the anatomy of interest. The way that I try and make sure that I have the anatomy of interest is I actually take the same stick that I use to figure out my bisecting angle, and I use it kind of as an extension along the side of the X-ray unit. And I basically run my stick right around the tube of the X-ray unit as an extension that shows me what anatomy is being encompassed in there. I would love if somebody could make an X-ray unit that has a light in it, because then I wouldn't have to do the stick thing. And then I could just see where the light is hitting, and that would encompass the anatomy. But until that's invented, just use a stick to sort of walk it around. Needs a light, right? Right? We could make a lot of money out of this. Yes, cone cutting is really, really easy to do. And my goodness, it is so much harder the larger the animal is. So if you've got a Great Dane, you're going to like need to take 2 or 3 radiographs every time. It is super common. It's much more fun to radiograph small dogs or cats because you don't run into this problem as much.
Dr. Fiani, could you help us with a few questions? Aviva is asking, where would you put the stick?
All right, so I'm gonna use this mug as an example. So this is my X-ray unit, right? And I'm interested in the anatomy down here, but I can't really tell if my X-ray unit is in the right spot. And so I'm going to take this stick, which is just a pen right now, and I run my stick around the unit sort of as an extension. Can you guys see that? There. As an extension to show me what anatomy is being encompassed. That's all. It's honestly like the lowest tech option.
Great, great. And a couple of other people are just wondering how far it should be. Is the cone touching the patient?
Absolutely. You need
Or
it as
how?
close as possible to the animal. That's the
Got
that's the rule. Although sometimes we try and get a little tricky. And if it's a really huge animal, if you lift the X-ray unit a little further away, because the X-ray beam isn't perfectly straight, it comes out more as a triangle. It'll actually encompass a tiny bit more anatomy, but it does sort of fluff around with the image a little bit. So be careful not to overdo it. But technically, the X-ray unit should be basically touching the patient. All
Perfect.
right. Dental plates are expensive. Is it a good investment to go for both small and large plates? I think you need the most important plate size is a size 4, which is the large plate, and then a 2 and a 0. Absolute must. It is worth it. You will make them back very quickly. Okay. Let's see. Okay. All right. What does everybody think is going on with this plate? Cut the root. We sure did cut the roots, but why did we cut the roots off? What did we do wrong in this kind? Because I don't, do you think it's a collimation error again? Do you think it's cone cutting? Uh, Oof, incorrect angle, too close. Straight. Oh, plate is misplaced. All right, now we're getting somewhere. Plate error. Okay, perfect. So one thing I want to point out is pretty much this whole plate has been exposed. So all of this plate was in the X-ray beam itself, inside the primary beam. But for some reason, we're not using up all the real estate that we ought to. We've only caught part of the anatomy of interest. So it's a plate placement error. So in this case, we have a plate that's being placed sort of incorrectly. So if you look at this X-ray beam right here, if I go straight down, just to represent, I'm not falling onto the plate anymore. I'm falling into pure air at this point. So where do you think we need to move the plate in order to correct this? In. Okay. So medially. Perfect. Everybody's getting this so well. Wow. Alrighty. So if we move that plate a bit more medial, all of a sudden we've given ourselves a ton more real estate for that shadow to fall onto. So the fact that it was too lateral means that, you've exposed nothing. You've exposed the tongue at that point, and that's not going to capture the image for you. So just shift it in a little bit. And it's important to recognize the difference between that collimation error, where you can actually see the external part of I'll just go back a wee bit. So you can actually see this white unexposed area, and that's because the whole X-ray beam is off center, as opposed to here where the whole thing is pretty much exposed, but the plate wasn't sitting in the right spot. Perfect. All right. Okay, I quickly saw somebody mention that they get turned around in the mouth, and that is a very common issue. All right. First of all, before we move on, does anybody have any questions as far as the common mistakes that we've encountered all the time? Okay, good. Super. Okay. Those are by far the most common sort of technique errors that we see all the time. All of them are very easily fixable as long as you sort of understand where the mistake comes from. How do I not keep doing it? Practice, I'm afraid. And understanding where the error originates from. Okay. Alrighty, you guys. All right, so orienting dental x-rays is a vital skill. So what you guys might have noticed, those of you who take a lot of intraoral radiographs, is that there is very, very little information on the actual plate itself. We basically don't have enough room for you to have a ton of information on these plates. So there are no left and right markers, ain't no space for it. There is no indication if you are dealing with a maxilla or a mandible. There's no ID of the teeth in there, although you can add all of this information as you go along. However, here is my warning. It is super, super, super easy to put incorrect information in there. Human error is a huge issue here. Occasionally you'll have them where they have the client name, the patient name, the hospital, whatever other information on there, but that's not really going to help you a ton when you're trying to figure out if this is a maxilla or a mandible or a left or a right, or what's going on. Where are you in the mouth? Okay, sorry, there's a whole bunch of questions coming in. Interesting. Does the plate placement error? Can we come back to some of the placement errors? Is that okay?
Sure, sure. I think that sounds great.
Alrighty. So you guys keep your questions. I'm just being bombarded, which I love, but we may ask you to maybe repeat these a little bit later and we can have a proper chat about them all. How does that sound? All right, super.
Great.
Okay. Okay. So this is what we have sent you guys out. We sent you a couple of full mouth radiographic series, and I want you to be able to practice to labially mount, which means to position all of the radiographs. You are taking anywhere between 10 to 14 x-rays per patient that you need to be able to look at, you need to be able to assess and interpret all at the same time that your patient is under anesthesia. Again, it's a really big ask. And if the information isn't on the x-ray itself, it is up to you to figure out where in the oral cavity you are. I cannot stress how important this is to avoid mishaps, to avoid extracting a tooth on the wrong side of the mouth, to avoid leaving teeth in that should have come out. It is super, super common to do all of that. And part of it is that you have so many radiographs to look at. And so if you don't have a systematic way of laying them out and knowing where you are at all times, it is so easy to make mistakes. Okay, so how do we achieve labial mounting? Labial mounting is done in 3 steps. And by the end of this, you should be able to recognize maxilla and mandible and left and right. Okay, so let's follow these 3 steps. And this takes practice. So don't feel bad if it takes you a minute to put your, gather it in your mind. So step number 1 is figuring out if the radiograph you are looking at is maxillary or mandibular. In order to figure that out, we rely on very important landmarks that help us figure out where we are. So here are the maxillary landmarks that you need. Number one, palatine fissures. These are two fissures in the rostral maxilla. Very, very easy to identify. That is where the vomeronasal organ cruises through and opens up into the nasal cavity, okay? Into the oral cavity, excuse me. The bright white line, this is my absolute favorite radiographic sign that helps me identify the maxilla. On the lateral views, we have a very bright white line that you can see here as well on all the lateral views. All the bright white line is the hard palate that you're capturing on the side. That's all it is. You're just seeing summation of the hard palate and the side of the maxilla on top of each other. The bright white line is your best friend. Next, three-rooted teeth. Remember our dental anatomy? We do not, or we should not have three-rooted teeth in the mandible. So if you're seeing three-rooted teeth, so here is a maxillary fourth premolar, and you can see three roots here. This is the maxillary first molar. It has one huge palatal root and a couple of smaller buccal roots, right? So three-rooted teeth. And then finally, when we're taking maxillary views, because of the way that we take these x-rays, you will never see the top of the maxilla. So typically all your radiographs will go to the edge just like this. You do not see the top of the maxilla at all, okay? Mandible. How do we identify the mandible? Well, first of all, there are two mandibles, and they articulate rostrally at the symphysis, which is a true fibrocartilaginous joint. So the symphysis itself is a wonderful giveaway that you're dealing with the mandible. No three-rooted tooth, or I should say there should not be three-rooted teeth. Occasionally we get weird random anatomical variations, but for the most part, you should not have three-rooted teeth in the mandible. The mandibular canal. Okay, so this is a true canal in the ventral third of the mandible. It contains the neurovascular bundle that supplies the teeth and eventually exits rostrally at the mental foramina. Okay, so it is a nice radiolucent space below the teeth of the mandibular dentition. Tips to remember left and right. We will get there. Okay. And then finally, as opposed to the maxilla, where you never see the end or the top of the maxilla, the mandible, you often see the ventral margin. You can actually see it right here. It's this nice thick cortical bone that is away from the crowns of the teeth. So it is apical to the teeth. You can see the bottom of the mandible often. Okay. So again, what we want to do for step one is identify all of the maxillary teeth. And if you're doing the puzzle, you're going to put them in the top part of your little space. And you want to identify all of the mandibular teeth and put them in the bottom part of the space that you're working with. If you're doing this radiographically, then they go in the top part of the screen or the bottom part of the screen. Okay, and here is a nice little summary of the identifying features of the maxilla and the mandible.
Doctor, would it be okay if we took a few minutes
Yeah, of
to
course.
go through a few questions? That's great because I see some people asking how long we might be going here. And my guess is that we'll go over an hour, but
Yes.
I'd love to go through some of these questions because also I think they're not only going to be helpful to everyone here, but they'll also be helpful to us as people are submitting consultations on Radimal. We've just seen how proper technique and everyone feeling confident really helps. And so there was a follow-up from a question earlier from Michelle. Could you just review the recommended plate sizes again? I think you said 4 was the important one.
Yep. So the size 4 is critical if you deal with dogs at all. Size 4 is very versatile. It accommodates the most amount of anatomy while still fitting very comfortably into the oral cavity. And again, I'm talking about photophosphor plates. With DR systems, they typically usually only come as a size 2, although there are manufacturers that are making size 4 plates. They're just prohibitively expensive in most cases. So if you're using photophosphor plates, size 4 is key. Size 2 is very versatile. After that, we use that a ton. And then a 0 is really nice for small cats and tiny dogs for sure. So those are the 3 sizes that we keep. Everything outside of that is, is a bonus.
Great, great. And what about exposure settings? Are there different exposure settings that people should be aware of, or different exposure settings that you use on different teeth?
The nice thing about dentistry is they've really dumbed the system right down for us, which is wonderful. The only variable when it comes to intraoral radiographic units is time. And so depending on, and that's where distance is eliminated as a feature, right? Because we want to put the X-ray unit as close as possible to the patient. And so time becomes the only variable. You don't need to change the KV or the MA. And depending on your unit, they're super variable. If you don't like the way the image looks too light, too dark, then you just up or reduce the time. So it's nice that they've made it time be the only variable. And sorry,
Great.
this can go for up to an hour and a half, this talk. It all depends on how many questions you guys have as we're going. So
Thank you.
I'm here all night.
Great, great. I've one more, and it's a little beyond my understanding, but may able to be helpful. Someone was just asking for tips for remembering the left and right sides for the 104 to 204 and 404 to 304
We're gonna
sharp.
get there. That's all
We're
part of
gonna get
orienting the
there.
dental x-rays for sure. Yeah.
Okay, let's
So
stay
we are
tuned.
only up to step 1 of 3.
Great.
All
Let's
right,
keep
so
going. Thanks.
I will continue. So number 1, make sure you understand maxillary and mandibular dentition. Do not get them confused. Okay, so now that we figured out which ones are maxillary and which ones are mandibulars, step 2 is orienting the teeth to point in the correct direction. And this is a step, in my experience, that people like to skip, but it is the most crucial step to not confusing left and right, which is the last step. Okay, so I want you to always point all of the maxillary teeth down. All the crowns should be pointing down. All of the mandibular teeth crowns should be pointing up. Okay, it's a very easy step. Please, 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 I cannot stress this enough. Do not skip it. It should hurt your eyes if a mandibular view has the teeth pointing downwards. That should be very painful for you. Okay, so now we figured out maxilla and mandible. We've pointed our teeth in the correct orientation, depending on maxillary and mandibular. And now comes the big and probably the most challenging, which is figuring out left and right. Okay, so here's what I want you to imagine. I want you to imagine that you have an animal that is looking at you, it is looking to you face to face, and you have very cruelly come along and split his head open from the back and laid his face out flat so that what you're looking at is a great big Cheshire cat grin. And that is how we are planning on arranging the teeth in order to figure out right and left. This over here, this image right here is perfect. What you want to do is you want to lay out the teeth so that the incisors are in the middle. On either side of the incisors should be canines where the crowns are pointing towards the incisors. Following that should be rostral premolars. And again, this is where root number becomes super important. So 1, 1, 2, 2s. And you can see how they are mirror images of each other, right? And same with the caudal premolars and molars. So those 3 3s, you can tell that this is the carnassial or the 4th premolar, should be at the end of your row. If you lay them out correctly, it should look as though the animal is grinning at you, right? And that means that this side is the right and this side is the left because it is looking at you. So one way that some of the students seem to remember how to figure out right and left after they've laid it down is when you go to shake someone's hand, your right hand goes across to shake their right hand. And that's exactly what you're doing here. The right side of the animal is on this side of the screen or the left side of the screen, right? They are looking at you, big Cheshire cat grin. So this is what the end result looks like. Over here, we'll look at the maxilla. You can see we have the incisors on this beautiful occlusal view. On either side, we have the canine teeth pointing towards the incisors because we've taken that mouth, we've split it open from the back, and we've laid it down flat. and then followed by the rostral premolars, which we like to take as a separate view, and then the caudal premolars and molars up here. Same with the mandible. Incisors in the middle. We've split that head open and laid it out flat from the back. And we have canines pointing towards the incisors. We have the rostral premolars followed by the caudal molars, premolars and molars, right? So you can see here, this is the perfect labial mounting. Right side, left side of the patient, everything is laid out. The animal is always grinning towards you. When you do this often enough, we can lay down one radiograph and you should be able to tell me exactly where it comes from. If it is maxilla or mandible, if it is left or right, and which tooth or teeth we are radiographing. Okay. I may have missed a lot of things. We usually do not mount our rads. So that's a great point. So almost all of the X-ray systems actually can provide you with labial mounting. They just don't do it automatically. You have to ring up the company and say, hey, can you please create a template for me that looks like this? And it's perfect. You just drag and drop each radiograph into its correct location so that ultimately, when you have completed your full mouth series, you have a labially mounted series. But it is fantastic. You know, IM3 does it. Lots of other companies have it. You just kind of have to ask them for it. And here is a cat, exactly the same. Incisors in the middle, canines pointing towards it, followed by the caudal dentition. Same for the mandible. I'm sure that Progeny does do it. You just have to call up, it's basically the software. So you really need to call up the software company and say, I would like to labially mount. This is the standard mounting system in humans as well. So it is not out of their range. This is very much what is expected for human dentists. All right. Isn't the maxillary laterals in the group of sixes mixed up? I'm not sure what that means.
I think they meant on the last, just on the previous slide. I'm not sure exactly what they meant.
No, I don't know what that means. Anyway.
Okay.
Okay, perfect. So this was a very quick run through of the 3-step process in order to get labial mounting. And I cannot stress enough how important this is when it comes to trying to interpret these radiographs in an efficient way and not missing stuff. You have 42 patients in a dog and 30 patients in a cat to be able to assess, review, and come up with a treatment plan for. So you've got to really try and help yourself as much as possible. Okay. All right. One thing I want to point out, and please, please be so careful with this. When you are exposing your X-ray plate, so this only applies to photophosphor plates, which is this plate right here. Make sure that you are exposing the correct side of the plate, okay? The plates go into a little sleeve and then they go into the mouth. If you inadvertently flip the plate over so that you are exposing the back of the plate, what will happen is the computer doesn't know, and so it processes it, and what you will get is a reverse image, a mirror image of the tooth that you've taken. So all of a sudden, we've gone from having a left maxillary canine view to a right maxillary canine view, and that is hugely problematic, right? So please, please be so careful. Some of the plates actually have a built-in mechanism, and if you look really carefully, you might see this watermark right here. It's a little square that alerts you if you've done that, but they don't all have it. So please be so careful that you always expose the white side of the plate, the correct side of the plate. Okay, be super careful. What if you use the automatic processing plate? How can you verify? If you mean direct radiology, so if you're using a sensor, the sensor can only go in one direction. It's much easier to not do this. This is only really something that I've ever seen with photophosphor plates. Okay, all right. Here's our little quiz. Okay, so which jaw is this from? Are we maxilla or are we mandible? All right.
Got a little bit of both.
Yeah, I think mostly people are getting it right though.
Great.
Okay, perfect. So I love seeing it. Okay, so the giveaway here is this beautiful bright white line. So if I'm telling you it's a bright white line, what does everybody want to say? All right, it's a maxilla. I love it. So which direction should these teeth be pointing? Down. Love it. Okay, so we're going to orient it so that the teeth are pointing down, which makes this, if we look at this radiograph, remember we have our incisors in the middle, we have canines pointing, and then we need to remember our dental root formula, 1, 1, 2, 2s, 3, 3s. So what side does this make? Ah, right. Excellent. Everybody's getting it. I love it. You guys are amazing. Right maxillary rostral premolars. My goodness. Wowee. Okay, one more. Maxilla or mandible? Okay, mandible. We're getting this one right. Okay, the big giveaway is that we have the mandibular canal. We can see the ventral aspect of the jaw. And then for me, this big mandibular M1 is always a giveaway in dogs. Okay, which way do we want to orient this radiograph? Where should the teeth be pointing? Up. Love it. Okay. So now that we've pointed the teeth up, we're going to think about where the incisors go, followed by the canine, and then the caudal mandible comes in afterwards. And so what side is this? Left. Love it. You guys are so good. Left caudal mandible. Excellent.
Great.
I love it so much. Okay, one more. One last quizzy poo. Okay. What do we think is wrong here? Okay, perfect. It's a maxilla. I love it. We have a maxilla. We can have more than one issue. Okay, it's elongated. Okay, I love it. Do we think that this is the issue here is obviously we can't see the apices. We can't see the tips of the roots, which is problematic because we love seeing the tips of the roots. Plate. Oh, okay, love it. Okay, so I saw tons of people say elongated. I agree. We are missing the plate, the tips of the roots. And in this case, is that because we are a plate placement problem or a collimation problem? Plate. All right. Perfect. Love it. So not only that, but some people have also shared that it is the right caudal maxilla and they are spot on. So we have a right caudal maxillary view where we have elongated the image too much and we've positioned the X-ray tube incorrectly. So we haven't collimated well. And that's why we have a non-diagnostic image on our hands right now. So very easy to correct, very easy to push the plate medially a little bit and to ensure that our sun is just a little higher up in the sky. Love it. Okay, so I'm going to check in now and just see how everybody's doing. And if we want to keep going, the next part, which is the last part of this talk, we're only going to be focusing on how to interpret dental radiographs. So I'm sort of just checking in, seeing if everybody's well and alive. Love this so much. Oh, that's nice. I'm glad.
Great. Doctor, is there anything you want to share about, and maybe you'll get into it in just a moment, but about the interpretation work that you do?
Oh, of course. So through Radimal, this is going to be a brand new service that's being offered through the wonderful folks at Radimal is the ability for us to interpret some intraoral radiographs for you guys. Unfortunately, we don't have the capacity to do that in the immediate under the same anesthetic event right now, just because there's literally very few dentists in the world. But there's, we would love to help you guys out. So as you take your full mouth series, we will report on them in the way that you're going to see shortly and give you some feedback. We do tend to see a lot of really common mistakes, and that's everybody. I mean, no shame here. We're all learning. And we try and help you by sort of pointing out where things could be done a little bit differently next time and what other diagnostics or where else you could potentially go with those cases. And we're very open to feedback. We're very open to questions. So if you're like, what's wrong with this tooth? What do I do with it next? We can certainly try and help you out a little bit more on that end as well. Please keep going. I love it. I'm in the marketing department and this helps. Oh, good. I own Tyson the Frenchie that regrew the jaw.
Oh,
What? That's amazing.
wow.
Oh, wow. Alexa, Dr. Wright will be thrilled to hear that. Melissa, thank you for letting me know. That's so cool. Okay, sorry, got a bit excited. Personal story here, but very cool. All right, moving on. So, as I said, you are taking anywhere, if you're really good and you don't have any spare films, you are taking anywhere between 10 to 14 radiographs per patient. And as I said, if you do not have a very, very consistent and logical way of looking at these radiographs, it is super, super, super easy to miss things. And so what we try and do is we have a very systematic approach to looking at the radiographs and interpreting them, and we generate a report that reflects that. So what you guys are going to see now is very typical of the types of reports that you would be receiving if you decide to send us any of your radiographs. So what we like to do is we have the full mouth series here, and we like to look at the quadrants in a clockwise direction. So we start with the right maxilla, we move on to the left maxilla, we move on to the left mandible, and then the right mandible, and we sort of just go round and round in a circle. We always start from the most rostral dentition and we work our way back. So we start from the incisors and we work our way all the way back to the last molar. And as we do this, we assess 4 categories for every single tooth. Now, if the tooth is completely normal, we don't write anything. However, the 4 categories that we look at are as follows. There is the anatomical and developmental, there is periodontal, there is endodontic, and then finally there is the category of other, which is a catch-all for anything that doesn't fall into the first 3. So let's go and take a look at what each of these categories sort of entails. And this is, I would urge you to please try and do the same thing in practice. There's no reason you can't do most of this yourselves. Okay, so let's start off with anatomical and developmental. So what we're looking for is really anatomic variations that may or may not necessarily impact what we're doing in the moment, but are still very relevant because they are out of the norm. So what we typically will record is any variations in tooth number. So if the tooth is missing, we'll say that it's missing. If there's an extra tooth like we have here, then we will point that out because extra teeth can matter if there's crowding, for instance. So over here, typically you should only have 3 incisors in the right maxilla. In this case, we have an extra incisor, so very common in brachycephalics. Root morphology variations is a really important radiographic finding, and it's a very common one. So things like supernumerary roots, and so that's where you have an extra root where you shouldn't. So this is a maxillary third premolar, right? Maxillary third premolar in a dog, and it has an extra root right here. In itself, it's not of any clinical significance to just find this. However, if this tooth has something wrong with it and you have to extract it, it is really important to know that you have an extra root there that needs to also come out. So critical at that point. Fused roots. So roots that are coming together either as a single root or are just sitting super close to each other. Again, in itself, it's not really a problem, but becomes a problem if that tooth needs to be extracted for some other reason. All of a sudden, I've gone from a surgical extraction where I'm sectioning this tooth in order to get it out to a simple extraction. It is one entity. I'm just going to pop it out as a simple extraction. So that's the kind of information that it becomes very relevant. Dilacerated roots or curved roots, it's just a fancy term for curved. Oh boy, these are my least favorites. When you have this umbrella handle hook on the end of a root, again, in itself, not a problem, but if you have to extract that tooth, boy, that is a relevant piece of information to have on hand. Okay, it looks like there's a lot of, I don't know if these are questions or just chats.
Can I share a few
Yeah, of course.
questions? Because yeah, I think they're great because a lot of them have to do with acquisition. This one I really like because everybody wants to feel more confident. How much time should it take to complete radiograph acquisition with everything that you're talking about?
Just the acquisition itself.
Yeah. So
I
Mary's
mean,
asking, how long should the rads be taking?
so just to take the x-rays and just physically acquire the radiograph so that they appear on your screen, honestly, it varies a little bit. So for a cat, and if you are experienced it'll take 15, 20 minutes. If you're a really good technician or radiographer, boom,
Yep.
15 minutes, no worries. The dog is a little bit more variable because it varies with size. The bigger the animal, the longer it will take to acquire the radiographs, just sheer size and volume. And the number of x-rays that you need to take suddenly increase all of a sudden. So I would say for a dog, a small dog, again, similar to a cat, 15 minutes or so. But for a large dog, it can take up to like 30 minutes, 45 minutes. So, and
Wow.
I'm a little bit more, I will admit fully that we are a little slower here because we have students and we let
Yep.
them take all of the radiographs. We insist on it because we want them to
Sure.
graduate and be able to do this themselves.
Yeah.
So maybe I'm probably even a little slower than what many in private practice might recommend.
Great, great. And speaking of canines, someone's asking how to get the whole thing in one shot. Do they or can they get everything in one shot, especially if they have a maybe a size 2 sensor? How should they shoot in order to try to get everything? The question is, how to get the canine in one shot?
So if you have a size 2 sensor and a Great Dane, you're just not going to do it. The tooth is
Okay.
way bigger than the sensor, right? So it's
Yep.
it's very simple, like real estate question. Um, the what you end up having to do with a larger animal and a small plate is take multiple views. And that's pretty typical. It's annoying because then it messes up the beauty of the labial mounting and you end up having three different views for one canine, but it is what it is. If you have the larger plates, then you sort of reduce the risk of that problem substantially. But even then, a size 4 plate, I mean, we do a lot of zoo work, so I'll use a zoo example. If I'm radiographing a lion's canine, even with a size 4 plate, I'm still taking three views to get that. So it's a pure real estate question. And, well, to some degree, sure, positioning the plate so that you get the most amount of the real estate is great. But at the end of the day, small plate, big tooth, multiple radiographs.
Makes sense. Makes sense. Okay. And this one's about cats. Any tips to not have the zygomatic arch
Oh.
not block the view in cats?
That's a great question. So, cats are the supermodels of the cat of the animal world, and they have a very prominent zygomatic arch, and it often falls right on top of your premolars and molars. That's a really commonly annoying feature. What we have found is there is an extra oral technique that is described, but it is really technically very challenging. We've actually just stopped doing it because it's a pain in the bum, to be honest with you. And so what we do instead is we elongate those images on purpose. And what that does is it tends to lift the zygomatic arch off the anatomy of interest to some degree. So even though your image is a little elongated, it is still very diagnostic and gets the roots off. So try elongating on purpose for the caudal molar area in cats.
Great, great. And this is interesting because I think it was asked earlier, and so I'm curious why so many people are asking this. So appreciate it if you don't mind repeating yourself. Is there preference for positioning of the pet? In fact, I just learned that there is. And someone saying we were told to place in lateral, but was taught dorsal and sternal in school. What would be the standard? I think you already touched on this, but maybe
Yeah.
since people are still wondering, thank you.
There's honestly no real standard, right? So even if the animal is in lateral recumbency, you just have to tilt your head and do exactly the same thing. You still have your plate, you still have your tooth, and you bisect the angle. It's just fiddly, that's all. So we prefer to do our radiographs in either sternal recumbency for the maxilla and then in dorsal recumbency for the mandible. That's how
Yep,
we prefer to do it. But a lot of people, fiddle around with them in lateral. It's really what
sure.
works best in your hands. If the lateral hasn't been working for you, give the dorsal and ventral a red hot go and see what happens.
Great, great.
All
Um,
right. Okay. I'm going to keep going with anatomical and
Please.
developmental findings. Is that okay?
Yeah, please keep going. I'll keep gathering questions. Thank
All
you.
right. So other things that we might note under anatomical and developmental are persistent deciduous teeth. So these are deciduous teeth that have not been shed. So this is a developmental abnormality. Unerupted or impacted teeth, like you can see right here. This is a mandibular first premolar tooth, very commonly impacted in dogs. Developmental cysts. So often around unerupted teeth, we get the development of a dentigerous cyst, which is a very frustrating lesion that forms only around the crowns of unerupted teeth and has an expansile nature. So they can get really big. They can, in fact, destroy a whole mandible if you let them. So it is always, always worth noting when teeth are unerupted, and they really should be extracted. We would note things like malocclusions. You can't always tell a malocclusion radiographically because malocclusions are dependent on relationships. So depending on how the maxilla and the mandible fit together, how teeth within the same jaw sort of fit together, but sometimes we can detect them radiographically. So in this case, what we have is a linguoverted mandibular canine. So linguoverted right mandibular canine. If you look here, the left mandibular canine is sitting at a completely normal angle, whereas this guy is completely shifted towards the midline. And so when this animal closes its mouth, this canine would be barging up into its hard palate. Not fun at all. Okay. So these are great examples of anatomical and developmental findings. Some may be incredibly relevant, others may be more of an interesting finding, but not really clinically relevant in the moment. Okay. What is that? Are you concerned with flipping the patient so much in dorsal to ventral? So we only ever flip them once. And that's kind of an advantage, is that we start with them in sternal. We get the radiographs of the maxilla, we flip them into dorsal, and they remain in dorsal for the entire procedure, and we don't flip them again. So we do all of our periodontal treatments, our dental extractions, everything is done in dorsal recumbency. Other places do most of their dentistry in lateral. They have to flip their patients. We don't, so that's sort of where we are. Okay, excuse me. Periodontal. So we'll go back to a quick periodontal refresher. So remembering that the periodontium is made up of the structures that essentially help to hold the tooth in position. So that is the gingiva, which you cannot see radiographically, the periodontal ligament, of which you can see the periodontal ligament space around the tooth itself, the cementum, which is the outermost layer of the root. It's the same radio opacity as dentin, though, so you can't see it individually. And then the alveolar bone, which you can see right here. So out of the 4 structures that make up the periodontium, only 2 of them are radiographically visible. So when we assess these teeth for periodontitis, which is loss of attachment to the teeth, we need to be able to sort of understand what normal is first. What we want to see in a very periodontally healthy tooth is as follows. Number 1, that the alveolar bone reaches all the way up to the cemento-enamel junction. So you want to see that the alveolar bone reaches to the neck of the tooth, essentially where the crown and the root meet each other. That's where your alveolar bone level should be. 1 to 2 millimeters off because of a little bit of parallax error is completely within normal limits and acceptable. 2, you want to look at the periodontal ligament space and see that it is sort of equidistant right around the tooth itself. You can see here, this is a very young animal, and you can see that the periodontal ligament space is lovely and very obvious and about the same size right around the tooth. Here's the trick. I never worry if the periodontal ligament space is really narrow. That's not a problem. That's probably heading towards ankylosis, which is very common in older animals. I worry a lot if it is wide. If it is getting wider, that's telling me that there is resorption of the bone, probably secondary to periodontitis. So I do worry about that a fair bit. Periodontal ligament space, get used to looking at what normal is. And then finally, for multi-rooted teeth, it is critical to assess the furcation, which is that region of alveolar bone between the roots. What you want to see is intact periodontal ligament space right here, and you want to see that what you have is a radio-opaque area that has this beautiful trabecular pattern. If you start losing that, that is evidence of periodontitis located in here. So this is a really nice example of healthy, normal periodontium. Okay. It seems like people are just sharing tips at the moment, so I'm going to keep going.
Yeah, it's wonderful. It's wonderful. Thank you.
Alrighty, so how do we define periodontitis or attachment loss? Well, the easiest way to do it is by defining it in terms of percentages of bone loss. So if we say that from the cemento enamel junction to the apex of the root is 100% coverage or normal, then any loss from there is periodontitis or loss of attachment secondary to inflammation from plaque. So what we define as mild periodontitis is less than 25% alveolar bone loss, which is, you can see a really nice example of right here. If this from the cemento enamel junction to the apex is 100%, this is about a quarter of the way along. And it's sort of a little bit subjective. We can sit there and pull out rulers, but at the end of the day, you can eyeball it as well. So that is a little bit of alveolar bone loss. It's considered mild. If we have anywhere between 25 but less than 50% attachment loss, that is considered moderate periodontitis. And then finally, if we have anything more than 50%, which is typically a great indication for tooth extraction, that is considered severe periodontitis. Now, as I said, it's really important to assess the furcation in multi-rooted teeth. And if you have that beautiful intact periodontal ligament space and beautiful radiopacity and trabecular pattern between the roots, then it's normal. However, if you have a little bit of radiolucency at the furcation, but you can still make out a trabecular pattern, then you have partial loss of alveolar bone, and that is considered furcation involvement. This in itself is not a 100% indication for tooth extraction, but it is an area of concern. On the other hand, if what you have is total loss of alveolar bone between the roots, so that what you have here is air opacity, that is black, then you have furcation exposure. And furcation exposure is 100% indication for tooth extraction. It is a plaque retentive area that cannot be cleaned or maintained, and therefore the tooth has to be extracted. So severe periodontitis or severe attachment loss, more than 50% furcation exposure, two very clear-cut reasons for tooth extraction. All right. Now, in cats have a unique way of developing periodontitis radiographically, especially around their canines, and that's buccal bone expansion. So rather than just losing bone from the alveolar margin towards the apex, they tend to lose bone but push the buccal bone sideways. So they just push the bone away, and you end up with an area of vertical bone loss right in here. So if you put your periodontal probe in there, it'll be straight in. You'll have like 8 millimeters of attachment loss. But they don't always lose the alveolar bone. They sort of just bulge it outwards. And you can see it here clinically. They tend to have these huge baubles on either side of their canines. They can develop buccal bone expansion in other regions, but the canines are sort of the classic location. Any questions thus far?
I have a couple of good ones if you don't mind. And there's one that I like because it's sort of the whole reason we've wanted to put something like this get together for a while. Someone, I think a doctor is asking, the techs in my practice are not that strong in dentistry, and I'm also new to dentistry, so I need guidance. What should I do? And obviously being here tonight is like a great step in that journey, but maybe you could, just help give a little bit of guidance there.
Of course. Yeah, it's dentistry is sadly a neglected area of education. I didn't have any dentistry when I went to Sydney Uni in Australia, and we didn't have any dentistry at all in our curriculum. And boy, did I pay for it when I first graduated. And I really feel for everyone because it's still not a readily available part of veterinary education as a whole. So you are not alone. The best way to sort of make up for that discrepancy, unfortunately, is to pursue CE. I can't stress that enough. Whether you go to the Veterinary Dental Forum, which is held every fall, that's a great place to sort of attend tons of lectures that are just purely focused. There's multiple tracks, so you can start with, beginner track, all the way through to very advanced tracks. They also have an entire track just for technicians. So there's lots of CE available out there. There's also a lot of textbooks that are very, very helpful. So the ABVA, I think, I will look it up and get back to you guys, but there are multiple textbooks out there that are usually quite helpful to guide you. But in all honesty, it's pretty scary to go from a book to a patient, which I
Yeah.
totally understand. So getting yourself into some CE courses is going to be super helpful. In fact, if you guys like what you're seeing here, Cornell does offer a lot of online CE options in dentistry. We have all of the diagnostic CE, so radiography, intraoral assessment, and conscious oral examination. So we sort of cover the gamut of diagnostics, and I'll send out that information later through Radimal as well. But it is very frustrating, and I'm so sorry that you're finding yourself in this situation, and
Yeah.
I hope we can continue to help you out.
Thanks, doctor.
No worries. Okay. All right, so we've covered anatomical and developmental. We've gone through the whole mouth and looked at those. We've gone through and looked at evidence of periodontitis and recorded anytime we've seen anything abnormal. And then finally, or not so finally, but third along, we're going to look at endodontics. Okay, so just a very speedy reminder. Again, you guys already got this before, which I was thrilled about. Remembering that endodontics is the field that cares about the pulp cavity, the living portion of the tooth. And as I said, blood supply and nerve supply enter the tooth at the apex, where it becomes the pulp, which is made of connective tissues, those vessels, and then on the periphery are those beautiful odontoblasts that make dentin throughout the life of a tooth. All right, so again, physiology is important. So how does endodontic disease come about? And the reason I'm going through this is I think people get a little bit confused around what's going on here. So basically, just very simply, teeth can die for a multitude of reasons. There's lots and lots of ways that teeth can be killed, whether it's a tooth fracture, electrical cord injury, whatever. Tons of ways that teeth can die. However, once they die, the cascade of events that occurs afterwards is always the same. Okay, so let's go through what happens and why we should care about it. So you are living your best life as a happy tooth. You're starting up here and you're just going about your business. Along comes some form of trauma, let's say tooth fracture. What happens is that will induce pulpitis, so inflammation of the pulp. If it is very mild, there is a small chance that that will go back to being healthy pulp. Majority of the time, unfortunately, it doesn't. What I want you to do is think about pulp the same, or pulp trauma, the same way that you think about traumatic brain injury. You have a beautiful, delicate, soft tissue structure trapped inside a hard shell. So if you come along and give it a great big whack, it's going to swell, it's going to bleed, and unfortunately, it's got nowhere to go. It is trapped in this shell, which means that it's going to necrose very quickly, right? Exactly like the brain. So here we are. We start off with pulpitis. Unfortunately, because of the trauma and its capacity to swell is very limited, you end up with necrotic pulp. No matter what you do, necrotic pulp will become infected. And what that means is that all of a sudden, you have this tooth that is not hermetically sealed. It has a sieve at the apex. Remember that we talked about the apical delta, which is a series of channels where those blood supply was entering? Well, that's an annoying feature now. So you have this very contaminated structure inside the tooth, and all of the inflammatory mediators that come with that disgusting soupy mess that's inside the tooth is actually going to start leaking out through the apex and inducing chemotaxis. So all of a sudden, white blood cells are being alerted, oh my God, there's an infection somewhere. And they rush towards the apex of the tooth to try and mop up that infection. So what you end up with is a huge inflammatory process around the apex of the tooth. Frustratingly enough, though, because there's no longer a blood supply entering the tooth, you have a very, very frustrating situation where those white blood cells cannot get up inside the tooth to clean out that infected necrotic mess. So what happens is you have this horrid constant cycle of crud and inflammatory mediators, and eventually, in some cases, even bacteria leaking out into the periapical tissues, inducing inflammation that has no way of getting rid of itself. So that is basically endodontics in a nutshell. Most of the time, histologically, when you are looking at that periapical tissue from an endodontically diseased tooth, you actually have a granuloma, so a chronic area of inflammation. Occasionally, it will become infected and you have true bacteria leaking out into that apex. So you often don't actually have bacteria there, but sometimes you will get bacteria itself. And that's the only time when you have a true tooth root abscess. So most of the time, it's actually a sterile inflammatory process around the apex, but occasionally bacteria will also leak out, and then you've got an abscess on your hands. Regardless, either way, you have osteomyelitis. It is excruciatingly painful, even though the tooth is dead. Remember that all the tissues around the tooth are very much alive. So that inflammation is painful, painful, painful. Okay, so how do teeth die? Well, there's a variety of reasons, as we said. One of the most common ones is tooth fracture with pulp exposure. Two, disruption of blood supply. So the tooth loses its blood supply. One of the common ways is actually through concussion. So the tooth gets a whack, bleeds inside, gets swollen, then goes on to die. Occasionally, most of the time, those become discolored, but not always. Jaw fracture is a really spectacular way of losing blood supply to a tooth. Severe periodontitis is actually probably the most common way that teeth become endodontically diseased. So what you have here is a pocket that's forming and getting deeper and deeper and deeper and deeper until the infection hits the apex and climbs up retrograde and kills the tooth. You can see here this huge periapical lucency associated with the severe periodontitis at the distal aspect of this tooth. So infection goes in, climbs up backwards, and kills the tooth. And then finally, oops, we have caries, which are cavities. Cavities are by far the most common reason for endodontic disease in humans, but we see them so rarely, thankfully, in dogs, probably about a 5% incidence, and they've never been reported in cats. So caries are an infection of the hard tissue structure that sort of breaks it down and the pulp becomes infected. Okay, looks like there's a ton of stuff going on in the chat. Let's regroup. What's going on?
Great. This is what I'm actually really interested in this, and we have multiple people asking this. Cleaning before or after X-rays?
Oh, so I prefer to do all of my diagnostics first, mostly because I start in sternal recumbency. And then we flip them over. I finish all my radiographs. I typically will even chart them, so periodontal probing and charting, before we clean the teeth. And then we clean the teeth, or our technician technically and our students will clean the teeth while we go off and look at those x-rays in light of our dental chart and come up with our treatment plan. So at all times, something is happening with the animal. So while the cleaning is being done, that is when I am interpreting all my diagnostics and coming up with my treatment plan.
Great, great. And I think we talked about this earlier, but there's still a few people just trying to double confirm here. What should be the distance between the tube head and the plate? I think you said very close, but I'm not
Not the
sure if I
plate, with the
understood
patient,
correctly.
because there's a patient between the plate and the tube, right?
Sure,
You want the tube as close as possible to the patient.
as close as possible. Yep,
Mhm.
great. That's already going to improve a lot of people's rads. I have a sense.
I hope so.
Um, great,
All
great.
right. All right, super. Okay, so radiographically, so we talked a lot about what happens with endodontic disease, how endodontic disease comes about, and now radiographically, what are we looking for? Well, there are four radiographic signs of endodontic disease. The first thing that we look for is loss of crown integrity. Basically, I'm looking for tooth fracture, right? It's one of the most common reasons for teeth to die, and it is also a very easy thing to notice on radiographs that the crown doesn't look quite right. So there you go. The next thing is failure of that pulp cavity to narrow. Remember that we said that pulp makes dentin, and if pulp dies, no more dentin is going to be made. So you're going to get arrested development. You're going to get a snapshot in time of when that tooth passed away. Failure of the pulp cavity to narrow. Again, once all of that pulp becomes infected and all of that inflammatory material leaks out through the apex, you're going to get a lot of inflammation. And with that, you're going to get resorption of the alveolar bone around the apex of the tooth. And that's where you will meet your periapical lucency, loss of alveolar bone. Now, with enough inflammation and enough time and chronicity, not only will you lose alveolar bone around the apex, you're actually going to start to lose the apex itself. So you're going to get inflammatory root resorption, and the tooth is going to look a little bit weird. So if you think about these, they actually kind of go in chronological order. The tooth fractures and then dies. The pulp is then going to, the pulp cavity is going to fail to narrow. Eventually, you're going to get inflammation around the apex. The bone is going to disappear. And then finally, the tooth itself is going to resorb away. Annoyingly, they're not all always present. I wish they were, and I wish they came with a rubber stamp to indicate this, but they're not always present. And chronicity plays a huge role. If that tooth fractured yesterday, the only radiographic sign I'm going to see is loss of crown integrity. There hasn't been enough time for everything else to manifest. The speed at which they manifest varies dramatically and depends very much on the type of bacteria and how virulent it is as to how quickly you're going to get a response from the tissues around the tooth itself. Okay, so here are some great examples. Loss of crown integrity. Here we have a left maxillary fourth premolar from a dog, and you can see right away that half this crown is missing. Nice and easy. A nice giveaway right here.
Mm.
Failure of the pulp cavity to narrow. This right mandibular canine, you can actually see the difference in the pulp width. Over here, it is way wider than its little friend on the left, telling us right away that the right side died, and it actually died a while ago. Next, periapical lucency. As we said, that the inflammatory mediators leaking out into the apex, and they start to resorb all the bone away as the inflammation persists. And over here, we can see some really nice examples of periapical lucencies. Periapical lucencies are probably the most over-interpreted part of endodontic disease. People see them all the time, including radiologists, and all I can say is they are definitely very, very overused and abused. My only tip here is it has to make sense. If you don't have a reason for that tooth to be dead, in all likelihood, what you're seeing is not a periapical lucency. Right, it's a chevron sign. A chevron sign is widening of the periodontal ligament space at the apex where the blood supply enters. It's just an anatomic feature that is very evident in larger teeth. Okay. Okay, and then finally, inflammatory root resorption. Look at that. Look at the difference in the length of these roots. So over here, we actually have a lot of radiographic signs in this left mandibular canine. We've lost our crown. You can see the crown on the left does not look the same as the right. We have failure of the pulp cavity to narrow. We don't have much of a periapical lucency, but we definitely have inflammatory root resorption. And you can see that because the root is much shorter on the affected side than the other side. So the tooth is being numbed away by inflammatory cells. Okay. Any questions around endodontic interpretation?
There's one, I don't know if it's directly about interpretation, but there's just a few people asking about if you could talk about predental antibiotics and your thoughts on, I hope I get this right, clinderol and doxarobe. I probably got that wrong, but are you
No,
familiar
that's fine.
with any of those?
If it's okay, I might answer that afterwards. I just sort of want to get through the radiology because that's beside radiology. So
Thank you
let me
so much.
finish through this. And yes, I can talk about pulse therapy and why it is naughty.
Great.
Okay, all right. So finally, we come to our final category, and that's the category of other, where we capture everything that doesn't fall into the first three categories. And that's really where we spend a lot of time talking about tooth resorption. So tooth resorption, super common in cats. Anywhere between 40 to 70% of cats will have some degree of tooth resorption, so super duper common. We definitely see a lot of tooth resorption in dogs as well. It doesn't tend to be as detrimental as it is in cats. And often it plateaus out a little bit. So over here, we have a couple of examples. This is a type 2 tooth resorption, type 3 tooth resorption affecting this tooth right here. And then over here, we have replacement resorption, or colloquially known as ankylosis in a dog. Other things we might note under the category of other are neoplasia. So here's a fibrosarcoma in the rostral mandible of a dog, and you can see the extensive geographic loss of alveolar bone. The fact that the teeth are sort of just floating in this soft tissue blob is very indicative of an aggressive process and a fast-moving process. We will note things like jaw fractures. Unfortunately, more common than we would like, either pathological or trauma or even iatrogenic in some cases. So you can see here, and then we might even notice some caries. As I said, they are very rare, but they are super fun when we find them. And it typically looks like an apple bite right out of the tooth. We'll even make some comments if we see abnormalities in the nasal cavity. So your intraoral radiograph of the maxilla, especially in cats, the occlusal view actually captures a really nice image of the nasal cavity. And if we see something weird there, we'll point it out. At that point, further assessment by a radiologist might be indicated. So here we are. We've gone through all the things that we intended to talk about. And I'm just going to leave this here while we answer all your questions. I don't know what time it is already.
Thanks.
Not too bad.
We're about an hour and 40 minutes in. Thanks for being so generous with your time and all of your knowledge here. I think we're doing pretty well on questions. If anybody has any, please feel free to share them here. Um, One person had a follow-up question about cleaning teeth before or after RADs. I believe you said go ahead and do your diagnostics first. They're concerned about tartar distorting radiographs. True, false, myth,
Uh,
reality?
okay. Let me show you an example of calculus. Where did it go? We'll just go back real quick. So I think this case right here is full of calculus. You can actually see these
Mm,
weird little bridges and
yep,
this sort of like halo of radio opacity around the crowns.
yep.
That's all that calculus is. It's of no concern if you know it's there. It's not going to interfere with anything.
Tartar doesn't interfere. Oh, myth. Okay, great. Thank you. Thanks for
But let
help.
me answer the question as far as antibiotic therapy. And
Great.
let me be very clear that I'm talking about periodontal disease. I'm not talking about endodontics. I'm not talking about anything else. Routine periodontal disease, so gum disease, plaque induced. There are three phases to consider. There is the preoperative phase, which is like the week or so leading up to periodontal treatment. Some people love to put these dogs or cats on antibiotic therapy in the lead up to a dental treatment to like help their soft tissues. Unfortunately, the best that you're doing is you're creating resistance. Plaque is a biofilm, which means that it is super protected from whatever you throw at it. And that's why we have to mechanically remove plaque and calculus from teeth.
Mm,
It's the
mm,
only thing that disrupts it. And so giving oral antibiotics or systemic antibiotics, there isn't even a blood supply to the crowns of the teeth. And so you're honestly wasting your time trying to treat something that isn't going to be treatable without any mechanical removal. So preoperative antibiotics for periodontal disease is a big no-no. Don't bother at all. Intraoperative antibiotics is the next phase that we should consider. And that is when the animal is under anesthesia and you are about to perform your periodontal treatment plus extractions. At that point, your concern is not oral. Your concern is systemic infection. So that is, you are about to make that animal bacteremic. Granted, it's been bacteremic for years, probably before it's seen you. Every time it chews, it's sending showers of bacteria into its system. However, you are going to make that a little bit worse by performing your periodontal treatment. So you come along and you're worried about sending showers of bacteria into the system. Okay. A
perfect. Thank you.
healthy animal will clear away bacteremia by itself within 20 minutes. They don't need you. They are perfectly capable of dealing with the bacteremia themselves if they are immunocompetent. So that means that really the only animals you need to worry about are the immunocompromised animals that cannot clear away that bacteremia. And so that leaves you with animals that are hyperadrenocorticism, that are diabetics, that are on immunosuppressive medications, that are on chemotherapy. Those are really the main group of animals that we treat intraoperatively with a single dose of systemic antibiotics, usually a penicillin group. That is the only thing we worry about. We do give animals that have implants intraoperative antibiotics, although the guidelines might be changing around that as well. And then finally, subaortic stenosis is the only indication, cardiac indication for intraoperative antibiotics. So that's intraoperative. Finally, there's the postoperative phase, and that's do you
Yes.
send that animal home with antibiotics after you have performed your periodontal treatment? If you have done no extractions, you don't need antibiotics ever to go home. If you have done extractions, but that animal is otherwise healthy, you do not need antibiotics. It is super rare for us to send an animal home with antibiotics. At that point, what I'm worried about is infection of my surgical sites. I'm no longer worried about systemic infection. I'm worried about surgical sites. And so the oral cavity has incredible capacity for healing. It has a huge blood supply and it does not need you. So unless that animal has, again, super immunocompromised or the tissue quality is fundamentally incredibly damaged, that animal has undergone radiation therapy, for instance, or it has severe stomatitis in a cat, then I would consider antibiotics. But as a rule, nope. So you can see that we rarely touch antibiotics for our patients. Intraoperatively, we have our strict guidelines. Otherwise, it is super rare.
Got it. And I also now understand why you wanted to save antibiotics for the end here.
Yes.
Thank you for answering.
All right. Sorry, is
Great.
there anything else?
Um, Karen's asking, what about infection getting into the bone? I think that's a good one.
What about, I mean, it's the same, it's exactly the same concerns. It's the exact same guidelines as far
Right.
as what we just mentioned. So the oral cavity has an incredible capacity for healing. And if you remove the inciting cause for the infection, the body can heal itself just fine, assuming that patient is immunocompetent. So if you are dealing with severe periodontitis, if you are dealing with endodontic disease, by simply removing the cause of the infection, the body is thrilled and they're like, yes, I can now heal myself. And for endodontics, for instance, it can either be an extraction or in some cases, it might be a root canal that addresses that. So treatment is variable.
Great. Well, I'll leave it to you. Whatever other questions you'd like to answer here. I think everybody has just been sending a lot of gratitude, and I see a lot of people just talking about how excellent and how informative this whole
Good.
event has been. Thank you, Doctor.
I'm so glad. Oh, again, clinderol and doxyrobe. So I'm assuming you're talking about periosutics. So these are various types of antibiotics that are marketed to be placed in periodontal pockets to
Great.
help. They have been shown quite definitively to be as good as thorough periodontal treatment. So thorough cleaning is the same as placing any of these things in there. So you can do it if it makes you feel better. We don't. We just don't think that it is worth the money or the bacterial resistance that they're going to build. So as a rule, I would rather that you spend an extra 10 minutes really cleaning that area with good periodontal treatment than bothering to just shove it full of stuff.
Good, good
Apparently, I
enough.
have strong
Don't
feelings
shove
now.
it full of stuff. Great. Okay. Got it. Wonderful.
All
Wonderful.
right. Does anybody have any questions with regards to radiographs or radiographic techniques? I believe there were a bunch of questions, whoops, earlier that we sort of didn't quite get to because everybody was like coming in hot.
Sure, thanks. Yeah, I think if anybody has any, please put them in the chat. I think we've gone through most of the ones that we've gathered here. I'm not sure if I understand this one. Aaron's asking root canal or extraction preference. Maybe you could talk about how you consider each of those.
Sure. There's just one question about tips for brachycephalics. So
Oh,
let me,
please.
as somebody who has owned bulldogs almost exclusively, and I'm very embarrassed of that. I love me a brachycephalic, but they are an absolute dentistry nightmare when it comes to diagnostics. Everything is on top of everything. Intraoral radiographs, there is no magic trick here. We do exactly the same thing that we would do with any other animal. We just take the angle of the teeth into account. That's all. So their canines are pretty much sideways, and we will still work out the angle. At that point, you're almost in occlusal view. You're almost on top of the dog, trying to take. You're often like radiographing their forehead because their faces are so short. So there's no magic here. It's exactly the same thing. Their interpretation is very, very challenging. In fact, there's multiple papers now actually encouraging cone beam CT instead of intraoral radiographs for brachycephalic patients just because of the difficulty in obtaining radiographs in that in those breeds. Root canal versus extraction. Oh, it's not an easy question because it's a very big topic. So basically, if we whittle this down to discolored teeth and teeth that are fractured, with the fracture limited only to the crown, then root canals are a very viable treatment option. Otherwise, extraction is pretty much your next best bet. As far as when root canal is a better option versus extraction, it really depends on the tooth. So we only ever do root canals on clinically important teeth like the canines and the carnassials. Otherwise, we opt for extraction. And depending on the function of the patient and whether or not the client is willing to pay and return to make sure that those root canals have been successful. So there's multiple things to talk about. Maybe we can like do that as a whole topic on its own at some point.
Great, great.
Uh,
He, here's one about imaging. If suggestions for getting imaging of all three roots of triple roots, especially I hope I get this right, carnassial tooth.
yeah, all right. So carnassial teeth are a challenge to interpret. Sorry, let me just jump back here. I'm just trying to pull out random images that might be of use. So let's see. Oh, here we go. So over here, we have a caudal maxillary view, and you can see all three roots of this carnassial very clearly. And the reason for that is it is not a complete perpendicular, it is slightly obliqued. So if you change, not only do you have your correct angulation as far as the sun in the sky, you can either come in a little bit more rostral or a tiny bit more caudal. That will separate all three roots out for you. You will get some degree of superimposition, but that's the best you're going to get with these. So there are inherent limitations to intraoral radiography. Sometimes you just can't see the roots altogether. The maxillary first and second molars, this is the best you're going to get. Just the position of the teeth where they're located. This is what they look like. This is the palatal root. And over here, you can just make out the two buccal roots. They are really, really hard to interpret. We rely incredibly heavily on our oral exam and probing to assess these teeth. All right, let's see, what else? I've lost my voice. Can you do bisecting angles on mandibular teeth in cats? You absolutely can. They're rostral mandible, so they're canines. Absolutely. It's the same. There is no magic bullet here. It is the same concept. In dorsal recumbency, plate goes in, canine, angle, and then shoot. Senior animals with dead teeth extraction. It is,
Oh
again, I
yeah.
think endodontic seems to be an area of real interest here. Maybe we'll talk about having another lecture specifically on that because it's very hard for me to answer these without first laying down some basic information and grounds of, anatomy and physiology before we move on to that in-depth level of treatment options.
Yep.
I will put together a little bibliography of books to help you guys out. Let me write that down before I forget. And okay, so a little bibliography of books that I will ask Alan and Galena to send out to you guys.
Sure, yeah, thanks. I think our top question is just people looking to be able to watch this again. Of course, will be emailed, the slides will be emailed. We can see that Dr. Fiani is now putting together a book list. So we'll also be reading. I think you also mentioned, some of the education opportunities at Cornell. There's CE follow-up and from the looks of it, we'll be doing this again also together with you and Radimal, just offering more education like this. So thank you. Is there anything else you'd like to say before we go, Doctor?
No, but there seems to be one person who's very adamant to talk about fractured persistent
Oh,
deciduous teeth.
great.
Extract them. Do not let them sit in there. They absolutely go through the exact same process as permanent teeth. They will form periapical disease, periapical inflammation, and it is even more critical in babies because the developing tooth is right next to them. So not only are you getting bone that's infected, you're going to infect the developing dentition, which is going to erupt abnormally. So please, please, please do not leave these puppies in pain. They absolutely need fractured deciduous teeth removed as soon as possible. Okay. Super. I hope everybody got something useful out of this today and that you enjoyed it. And if you ever want to send through radiographic sets to Radimal, we would be more than happy to help interpret them and give you guys some tips as we go along.
Absolutely. Thank you everybody for joining today with Dr. Fiani. Thank you again, doctor. This has been really great.
Oh,
Thanks everybody, just for helping us put this webinar together in celebration of launching our dental consultation program here at Radimal. We will be distributing a recording, CE certificates, and other materials via email in the next few days. If you like, you can scan the QR code before you go and sign up. And looking forward to seeing you at our next webinar. Thank you so much.
bye, everybody. Thank you.
Thank you. Good night.